So besides patients in cornea, dry eye, cataract that I see, we also see a fair amount of refractive patients. And this is a patient who came to us for a toric ICL.
And not only did they have the astigmatism that warranted the toric, they were a -12 prescription. So they were ready to ditch those glasses and contacts and have a surgery to correct it. So the first step with the toric was going to be at the slit lamp to actually mark the toric markers.
Two good points. One, ready to ditch contact lens glasses. I mean, this is a patient who without them doesn't see anything. He's pretty much blind. And I do think it improves their quality of life significantly for them to be able to wake up and see something.
Oh, huge.
For the reason for the orientation and for placing marks sitting up is that all of our testing is done sitting up, and the patient can have up to 15 degrees of cycle torsion, meaning the eye can actually move when they lie down, which obviously for a toric lens, alignment is pretty important.
So this is the marking upright, seated at the slit lamp, and those marks will then stay for the duration of the surgery, even for a few days afterwards, and this is going to give the surgeon, in this case Dr. Fintelmann, the chance to know exactly where to align that toric ICL. First step is getting access into the anterior chamber with a variety of incisions, and that's what we're seeing in this first portion.
This is now the procedure, the way the procedure is advocated by STAR. They used to have a lot of variety in how the procedure was done. This is now the standard way. I put lidocaine with epinephrine to dilate and numb the eye, then viscoelastic. This is a very dilute viscoelastic called OcuCoat to pressurize the eye before I make the main opening.
Why is the pressurization of the eye important for an ICL? Why is that happening?
So two things. One, whenever I make an opening, otherwise the eye collapses because it's under pressure and I make an opening that then fluid can come out of. And two, I want enough room that stays so when the ICL goes in, it can unfold. This is the loading of the ICL. This is the relatively for us newer injector and cartridge that the lens just gets folded into. It stays here on this side and then on both sides it goes underneath and is vaulted upwards. Closed and then inserted into the eye with an injector that you see coming in here. The ICL tends to come out like this and then unfold. There is an orientation mark to make sure that the appropriate side is up.
So when you're loading it, you're looking at that orientation mark to get it so it's going to load. And is that always going to be on the far side from where you're injecting it, is where the mark is going to become?
There's a mark on the right leading and the left trailing haptic. And that ensures that the appropriate orientation is maintained at all times because obviously you don't want the lens against the natural lens.
Yes.
This now is viscoelastic on top of the lens to push it down before the little feet get placed behind the iris.
And there's 4 feet total, so we're seeing the manipulation of those to just place them behind the iris. This patient was really quite well dilated. Is this a typical amount of dilation, would you say, or do you need this much dilation for this surgery?
No and no. He dilated very, very well. So much so that we actually beforehand didn't even use phenylephrine to dilate, which is one of our dilating drops, but only tropicamide. And the intracameral lidocaine with epinephrine dilated him even more.
At this point, are you starting to think about your rotation, or did you just try to insert it in a place where you're going to need to have minimal rotation for the toricity?
First, I just want the haptics behind the iris because I can rotate the lens once it's in the appropriate place much easier, I should say more reliable than if it's in the front and then try to place the haptics behind the iris.
Got it. So we're just seeing those little portions of the ICL being placed behind the ICL, behind the iris, I mean. So far we have the 2 of them, and now we're going on with the final 2 here.
And this is a little bit more atypical. Usually it would go through the small incision. Here it goes through the main wound to place the little feet, but whatever is more easy to do and more reliable to achieve.
In some of these views, you can also appreciate little holes in the actual ICL itself. That's to allow fluid exchange from the posterior chamber through to the anterior chamber and making it so these patients do not need an LPI as part of this actual surgical procedure.
The iridotomies previously prevented pupillary block, but since there's now holes or ports that allows fluid to circulate in there, that is no longer necessary. In this case, I irrigate out the viscoelastic to make sure that nothing exists behind to lead to a higher pressure spike. This particular model requires at least 10 cc's or 1 minute of irrigation that we've obviously shortened here, and that has decreased the amount of pressure spike significantly. With this kind of procedure, the patient can see okay immediately after. Obviously, the eye's dilated and they're swelling, and by the next day, they see much better.
As you can notice, some of this is sped up a little bit to show that rinsing and washing out with those the fluid there. And patient, it's remarkable, going from a -12 with astigmatism, and after this procedure, I saw them for their 1-day post-op, and they were already seeing 20/15 with just a barely slight hyperopic refractive error. And I'm curious, was that the target to be slightly hyperopic, or is that advantageous in some cases?
So it depends on the age. Is on a high myope, and this patient was in their early 20s. I like to target some hyperopia because I expect them to regress a little bit over the next 10 to 20 years, so that we stay plano for at least the next 20 years, ideally. As you can also see, the optic has a certain diameter, so some patients with large pupils can see the edge. Also, if you're wondering if these little holes create some optic phenomena, they do. Usually it's a little ring, and there's a variable adaptation to this. I remember this patient didn't have problems for very long.
Yeah, they did mention driving in the dark, and they noticed a little bit of a halo around lights, but that would be a temporary thing that we see even after other refractive procedures that we would expect to get better and better the longer the patient adapts to that.
And here's one more test. That little wax cell is designed to suck up any moisture that might leak out of the wound to show me and ensure that the wound is watertight.